Discussion for today's video will be your ventral hernias. So when we are saying ventral hernia, it includes your epigastric hernia and umbilical hernia or paraumbilical hernia. If it is congenital hernia, then you can name it as umbilical hernia, otherwise mostly we call it as an umbilical hernia. Then incisional hernias, and then parastomal hernia, and Spigelian hernias, and lumbar hernias, traumatic hernias. Typically lumbar hernias they are dorsal hernias, but still they are included in your ventral hernias. And incisional hernia, to be specific more, it should be called as acquired hernias. So in detail we will see the types of hernias. So first, umbilical hernia. Umbilical hernia can be due to congenital weakness of your umbilicus, or it can be acquired. When it is going to be a congenital hernia, I want you to remember one more important association. It is associated with your hypothyroidism. And usually it is a small defect, and there is no chances of strangulation, so no need of any urgent intervention. Whereas in your acquired hernias, the most common causes of these acquired hernias, umbilical hernias, would be your obesity, ascites, pregnancy, those of which causes your increase in your intra-abdominal pressure, cirrhosis of liver, etc. So usually this umbilical bulge or the umbilical defect we measure, and if it is less than 2 centimeter, you can wait and watch. If it is more than 2 centimeter, then there is the risk of strangulation, so we go for surgery. Either you can go for open or lap. In open we go for Mayo's double breasting. It's nothing but like a Pantone vest repair. Or you can do simple anatomical repair. Next we will discuss on epigastric hernias. These epigastric hernias are also called as fatty hernia of linea alba. Fatty hernia of linea alba. So the most common content of these hernias will be your pad of fat, and there is a transverse defect. And there could be multiple small defects, and it is also called as a sackless hernia or a ghost hernia. Remember these synonyms. And one more important thing is that you must do a ureoscopy, since it mimics your peptic ulcer. And one more important thing is that if it is strangulated, no cough impulse could be appreciated. It is a sign of urgent exploration. Hence, epigastric hernias are surgically repaired by simple anatomical repair. Next we move on to very important topic in which there are repeated questions has been asked for you. Incisional hernias. Incisional hernias are also called as port site hernias, and it's most common in the midline, greater than paramedian, greater than transverse. There is EHS classification of incisional hernias. So if you see here, there is M1 for xiphoid, that is subxiphoid or xiphoid, and M2 for supraumbilical or epigastric, and this M3 has been asked in your INICET exam recently and in your Neet PG also. M3 corresponds to your umbilicus. So if you remember M3, it is umbilical, M2 is supraumbilical, M1 is xiphoid or subxiphoid, and M4 is infraumbilical, M5 is suprapubic. And there is also L1, L2, L3 and L4. L4 you can easily remember, it is an so lumbar hernias are L4, you can easily remember it, and L2 will be your flank, and L1 is subcostal, L3 is iliac. Same things are depicted with these things. So M, L, R is the mnemonic you remember for your EHS classification of your incisional hernias. So M for this your midline, where it is M1 is in the subxiphoid, and M2 is in your epigastric, and M3 is your umbilical, and M4 is infraumbilical, and M5 is supra. Also length and width also is calculated. If the width is less than 4 centimeter, it is W1. W2 is your 4 to 10 centimeter. W3 is more than 10 centimeter. Why it is important? Because it plays a very important role. If the defect size or width increases, then there is an entity called as loss of domain. The loss of domain means there is disproportionate between your internal or the intra-abdominal contents, volume of the intra-abdominal contents to your volume in the defect sac. So when there is a difference and the most of the contents are in the hernial sac, hernial sac contents greater than the intra-abdominal content, then it is going to be a loss of domain. There we will calculate Tanaka index. Just remember this name, Tanaka's index. So EHS classification is important because for knowing the anatomy and what kind of surgery or the choice of surgery to be planned is very important based upon your EHS classification of MLR. LR is for recurrence. Okay, and if the defect is going beyond 10 or more than 4, then also there is a role of TAR, that is transverse abdominal release. So some of the risk factors for your incisional hernias, one is surgery related, other is patient related. So patient related is immunocompromised state, anemia, diabetes, obesity, ascites. Okay, and surgery related you can again classify to surgeon and surgical complications. That includes surgical site infection and based on the type of surgery also. Emergency more common than your elective. And surgeons Risk factors include poor technique and Jenkins rule. What is Jenkins rule? Again, this has been asked previously. That is 4:1 of their suture length. That you go for your midline closure of their abdomen. Now what we follow is NMOS closure of your abdomen. This is called as Jenkins rule. If it is not followed, then again there will be a problem, and using of observable suture is again a risk factor. So next hernia what we will see here is a Spigelian hernia that is going to occur through a Spigelian fascia. So basically it is called as an interparietal hernia. Okay, it is an interparietal hernia. Why? Because it is occurring between the two parietal fascias. One is that rectal abdominis fascia, and it is remember this line, arcuate line. It is just above the arcuate line. Why it is important? Because below this, the important differential diagnosis for your Spigelian hernia would be your rectus sheath hematoma. Mostly this rectus sheath hematoma will be below arcuate line. Okay, and the investigation of choice for diagnosing this is CT abdomen. Okay, and you can, as well as like any hernias, you can see for the defect with cough impulse, and there will be a lump over the Spigelian fascia. Another important hernia is your lumbar hernias. Lumbar hernias, to be more specific, should be called as dorsal hernia, but it has been included in your ventral hernia. This is your inferior lumbar hernia. This is your superior lumbar hernia. So which is most common? Your remember left side is most common. So superior lumbar hernia is most common left side, most common is superior. Okay, the boundary is formed by your internal oblique muscle, as you can see here. And 12th rib on the superior side, and also your latissimus dorsi muscle, reflected part of your latissimus dorsi muscle, and serratus posterior. Okay, so 10 to 20% it will be due to congenital, and 45% it is mostly due to trauma or surgery. Very important. One of the post-traumatic hernias to occur is your lumbar hernias. And another thing is that, important thing is that most common content here would be your small intestine. Okay, and could be pad of fat alone. Okay, the other name for superior lumbar hernia is called as Grenfell hernia. Okay, and the inferior lumbar hernia is called as Petit's hernia. Okay, Petit's hernia is also common after post trauma, and it is very rare, and it is most commonly seen in old age patients. When compared to Grenfell hernia, Petit hernia is less common. Grenfell hernia is most common, and the repair for your hernias, lumbar hernias, is there is a old technique called as, just remember the name, Dowd-Banka technique. Okay, and 25% of this patient can go for obstruction. So hence repair is or surgery is indicated. So next is your parastomal hernia. I am just highlighting the important points that will be asked in your exams. Most common after your end colostomy. Okay, so they will be giving option, either it will be a colostomy or ileostomy. You have to choose. You have to choose colostomy. In colostomy, whether they will give end colostomy or loop colostomy, you have to choose end colostomy. Okay, EC. Remember, parastomal hernias are most common after EC. EC fine for end colostomy. Okay, and here I want you to remember one name for procedure called as sugar Baker technique or sugar Baker procedure. It is double mesh, and also there is a prophylactic mesh plasty controversial role for preventing your parastomal hernias. Okay, at this your level you will remember that parastomal hernias are most common after your end colostomy, and there is a procedure called as sugar Baker procedure which incorporates dual mesh techniques. Okay, so we have in short discussed about parastomal hernias. Lumbar hernia, superior lumbar hernia is most common. The left side is most common, that is called as Grenfeld's hernia, and most common after your post trauma. Inferior lumbar hernia is called as petit hernia, which is less common, and the technique you use for this is called as Dowd-Banka technique, older technique. Just remember the name. And Spicillin hernia occurs in the Spicillin fascia just above the arcuate line, and the differential diagnosis for this would be your rectosheath hematoma. The investigation of choice for that is CT, and in detail we have discussed about incisional hernia. In mainly we have discussed about the EHS classification. This has been previously asked in your exam, and there is a risk factors for incisional hernias, and the defect size and role of TAR, and the role of Tanaka index and loss of domain. And epigastric hernia is also called as fatty hernia of the linea alba, ghost hernia, sackless hernia. And umbilical hernia, it can be congenital or acquired. Congenital, there should be remembrance of hypothyroidism, nothing to do. If it is acquired, if it is less than 2 cm, wait and watch. If it is more than 2 cm, surgery is indicated. Thank you.